tonight. This is an MS Advocacy HUB program. And, we've been doing this now since the beginning of the pandemic. And I think that we're going to wrap things up tonight. We started with the National MS Society, and we're going to end it with the National Multiple Sclerosis Society. Okay, so we started, I think, with Dr. Coates, and we're going to end with the Executive Vice President of Advocacy and Healthcare Access, and this is Bari Talente, but that you'll see her in a minute. Right now, it's me, and we'll move on to the next screen, and this is supported by MS Views and News. And then our guest tonight, like I said, is Bari Talente. She's the Executive Vice President of Advocacy and Healthcare Access, and she does so much more probably for the MS Society that I couldn't even begin to state what she does. But Bari, before we even begin with the regular questions, I want to ask you, first off, I want to thank you for being here. And secondly, I want to ask you, what does the title mean? Advocacy and Healthcare Access, Executive Vice President. I mean, okay, I understand that part, but what is it that you're doing with the advocacy, and what is it that you're doing with healthcare access?
Yeah, thanks, Stuart, and thanks for having me. Hi, everyone. So advocacy and healthcare access. So, in my background, I kind of grew up on the advocacy side of things. So I have a law degree. I never wanted to do private practice. So I found my way into the legislative and public policy arena. And that's how I came to the National MS Society at first. And so I worked on our advocacy side for many years, probably about 15, 16 years. I've been at the society for 17 years now. And so what we do is we look at how can we change public policies to change the world for people with MS. And as we know, MS is a complicated disease. And so there's lots of different public policies that impact people, from healthcare and health insurance, drug prices, which I know we'll talk about in a little while, disability rights, transportation, long-term supports and services, quality healthcare, all of those pieces where you can impact public policy, which is kind of a fancy way of saying laws at the federal or state level. And so that's what we do on the advocacy side. And then part of that is, how do we help people with MS and their loved ones understand the process enough that they can engage, and give them talking points, what they need to know about different pieces of legislation, and how to find their authentic voice to tell elected officials what it really means to live with MS every day. And, a lot of what I just said relates on the advocacy side, a lot of that relates to healthcare. So we know that people with MS are going to have a better quality of life, a better course of living with the disease if they have access to affordable and high quality healthcare. And so that's how I came to take on the healthcare access work as well. And so that work ranges from building relationships with MS specialists and general neurologists, so they have the most up-to-date information, our clinical content, so information that explains what MS is or gives people affected by MS the information that they need. And we're doing outreach to healthcare systems and health insurers to really bridge those gaps in understanding of MS, to really build that affordable and quality healthcare ecosystem that people with MS need.
Gotcha. Thank you for that. So, I had a lot of questions with everything that you were saying, but I have MS and I forgot what my questions were. So I'll find them again in a few minutes, okay?
Yeah.
But right now, I wanted to let everybody know, though, that for most of them people that are online, you already know where the question box is. And if you have anything to ask about what Bari just spoke about, please type in your questions. I'll stop the program and I'll ask you questions. I'll ask the questions that are being asked based on the questions that we're going to go forward with as well, so that way we keep it relevant to what we were just talking about. So again, if you have any questions, just go to that red or orange rectangle at the top of the page, click on it, type in your questions, and I will ask Bari your questions, okay? All right, great, awesome. So far, there's not there. But the healthcare access, so when you're talking about this and the access to medications and the access to healthcare, how does that reflect on where people are living? Are there the same parameters do you use for urban America versus those that are in remote areas of the United States, or can you explain that portion?
Yeah, it's a great question. So, our goals for what exists for people with MS are the same, right? That affordable, high quality healthcare. But certainly the ecosystem around people changes based on where they live. So, different states may be friendlier to health insurance, for example, than others. And we know that we can have shortages of MS specialists in many rural areas, sometimes in urban areas as well. But that can look different for people in terms of access to healthcare providers. And so, in the past year, we've been focusing in more on building relationships with general neurologists because we know that not everyone with MS can get to an MS specialist. So we really want to make sure that general neurologists have the level of information that they need to effectively care for and treat people with MS from diagnosis on throughout the rest of their lives. So that's been a focal point for us.
Okay, so like when you're dealing with these general neurologists, the reason why I'm bringing up what I'm about to say is because I was on a call the other night with having conversation with people in southwestern South Dakota, and one of the people were telling me that she has not come out of her home in over 2 years because she's using a B cell depleter, and her doctor told her she should shelter. They didn't tell them anything about the antibody shot that's out there now, the Evusheld. They haven't spoken about anything else about staying away, for protecting yourself and what to do and whatnot. But just literally, this doctor told her that she needs to shelter. And so that's what she's done because she was afraid to do anything other. So people have been bringing her food and leaving it outside of her door. And I felt very bad for her. I mean, we're towards the end of this pandemic, and this lady knows nothing about it because she's listening to a doctor, her neurologist, that's just given her probably incorrect information.
Yeah, that is heartbreaking. I mean, so it's not surprising, I think, that the pandemic and COVID has taken up a lot of our focus and a lot of the work we've been doing over the last 2 years.
Sure.
And we've been gearing that information and education both for people with MS, but also for healthcare providers. So in fact, tonight also, some members of our team are having a webinar for healthcare providers where they're having a conversation around COVID. And part of that focus is around, we're starting to move from pandemic to endemic, which means it's kind of always there and we have to learn to live with it. What does that look like? What do healthcare providers need to be talking to their patients about, including people with MS? There's starting to be some conversations around maybe vaccine strategies look different for different people, depending on if you're immunocompromised or what you have going on in your life. So it may not be everyone gets 2 doses and then everyone gets a booster every 6 months or whatever it's, however it's been. That may look a little bit different depending on each person, a little bit more tailored to what's going on for each individual person. So, we have a group of advisors, medical and scientific advisors that are still meeting regularly a couple of times a month to really talk about what's up to date with COVID, what do people with MS need to know, what do healthcare providers treating people with MS need to know, to get information up on our website and to host programs both for healthcare providers and people with MS.
Yeah. So, you had what? You had your 2 shots and you had your booster, right?
Right.
Well, I'm one up on you since I got COVID, so it's like I got another shot, I mean, but fortunately I did well from it, right? Okay.
Yeah.
So that was just a joke I wanted to throw in there about that. The thing though is that again, we're dealing with a lot of people in these rural regions around the United States, and we're hearing from the patients, not just this person in South Dakota, but we're hearing from others in other regions, even as far or as near east as Western Virginia, not West Virginia, but Western Virginia. Okay. And that they're being provided information by their doctors that don't tell people to even get the booster. They're being told not to get the booster. Some are being told not to get the shot. This is by their own doctors. And it's very hard to educate people if they're, if we can't find a way to, maybe get the National Multiple Sclerosis Society to create a video, I mean, a real live in-person program, maybe that all the MS organizations can say, hey, send it out to all of our databases and say, hey, you've got to listen to this program. Listen to the experts. I mean, we're trying to provide the resource that everybody has of being on the internet, as long as they have internet. And generally, if they have a cell phone, they have internet, right? So that source is great for people to be able to access care, and they don't even realize that. They're not realizing that, they have a cell phone, they have a laptop, they have a tablet, they have ways to get on the internet and find the information, and they don't know because they're being steered in another direction. How do we?
Well, we do have, we do have a program for people with MS tomorrow. So the healthcare provider one is tonight. Tomorrow, as part of our Ask an MS Expert series, there is a webinar, and they run at 1 o'clock Eastern time. And tomorrow's is around pandemic to endemic for COVID. Okay. So some of these questions that we've been talking about, Dr. Nancy Sykott, who's amazing, who's an MS specialist. She's professor and chair of Department of Neurology at Cedars-Sinai in California, and she's been she chairs our National Medical Advisory Committee, and she's really been leading a lot of the work we've been doing around COVID. So she's going to be featured on that. And, those programs are streamed on Facebook. They're available through our website. And there's a URL, nationalmssociety.org / I always get that word wrong, MS Expert. But, we do these programs themselves run about 45 minutes, but then we're able to go in and sort of take snippets to be able to try and get them into shorter pieces. We're still in a place where a lot of the information is changing on COVID, so we want to make sure to stay up to date. That makes it a little bit harder to do some videos because it's not quite evergreen yet. But, right. These programs really let us get the word out, and then they're able to sit on the website so people can find them on their own and watch them at their leisure too. And again, we're trying to sort of snippet sound bites and smaller bites of information to make it easier for people.
Sure. What is evergreen? I've heard this so much lately, and nobody can actually understand this.
Yeah. So evergreen, when we talk about evergreening information, especially, it really means that it's not going to change a lot, that you can put the information out there. You don't have to worry about needing to update it because the information is going to stay. It's going to be the right information for a considerable period of time. Okay. So you think everything with COVID has definitely not been evergreen, right? So we didn't have vaccines, we had vaccines, then we have boosters, people who are immunocompromised have additional doses. So all of that information is constantly changing.
Great. Thank you for all that information. So I want to let everybody also know that, even there have been a few people asking us, why if we show that an event that we're doing online, a virtual event, why it's showing that it starts at 7 and ends at 8:30? Well, that depends on the amount of answers that we're getting from our guests, as well as the amount of questions that are being given to us to ask our guests. So if we end the program early, it may be because you might be the person also that's just not asking enough questions. So again, I will say that if anybody has any questions, please type them in. Otherwise, we might end before 8:30. Okay, thank you. All right, what can you tell us, please, about biologics, biosimilars, and generic medications? These are things that people are hearing a lot about now, but clearly, it's very difficult to understand. I mean, generic I could understand, but biologics and biosimilars, I mean, even I had to look that up and say, what the heck is this about?
Yeah, there's some complex terminology here. So we're going to walk through it, and stop me if you want me to spend more time on something. And this is definitely a place where if you're watching, chime in and ask us to slow down or ask clarifying questions. But so I'm going to add a fourth category. So Stuart mentioned biologics, biosimilars, and generics. So I'm going to add in sort of what I'll call typical or chemical manufactured drugs, right? So that's our fourth category. So let's start with that one, typical or chemically manufactured drugs. So that's really what you generally think about when you think about a medication. So it's probably going to be a pill that you take. It's manufactured through a chemical process, it's a lot of your standard medications. In MS, if you think about the disease-modifying treatments, generally the rule of thumb is that the oral medications fall under this. The oral medications are typically done through a chemical manufactured process. So the reason that I'm starting with this, why I added this fourth one, is the way the drug development system works, right, is that it can be very expensive to go through the research and development process. So you have to understand what compounds may work to treat a particular illness or target a specific mechanism. Then pharmaceutical manufacturers have to run that through clinical trials, usually a number of different trials where first you test for safety, then you test kind of dosage, and then you move into testing in people to see if it works. So all of that takes a long time. It's expensive. Ultimately, if a product works, it goes before the FDA, the Food and Drug Administration, to get scientifically reviewed and approved. So that's the process that all of our medications go through. So when a product's going through that process, it usually will have patents on it. And that means that the research into it and the process for developing it are protected through our country's patent process. And that's important because that means no other company can mimic developing the same drug while it's protected by the patent. Mm-hmm. So this is where then we move into generics. So once that patent lasts for a particular number of years, there's a period of time attached to it. So once a drug moves away from patent protection, then we can have generics for that product. So a generic for a typical drug is it's sort of identical in its chemical makeup. It also goes through the process through the Food and Drug Administration. So a generic company will identify the different chemicals that make up a drug. They'll go through a testing process, though not as extensive as for what's called a brand name drug or a typical drug. Right. And then that generic medication also has to get approved by the FDA. Because it's not as lengthy a process, there's not as much research, there's not the really lengthy development timeline, generic drugs can cost significantly less money than their brand or reference product, than the product it's based off of. And so you think about they're paired together, so you have your typical brand drug and then a generic drug when that comes off patent. Remember that generic has to prove that it's chemically the same to get approval by the FDA. So they are safe for people to take. So then we move into biologics. So biologics are also medications that people take. They are they're also can be referred to as brand or a reference product for the original, but they're called biologics because they're developed from a human or animal material. So that makes them biological. There's a biologic material that's part of them. There's a complex biotechnology process to develop them. So in the MS disease modifying treatments, generally you can think of that self-injectable or infused products are typically biologic products. Copaxone's an exception to that, but again, this is a general rule of thumb that self-injectables and infused products are going to be biologics. So, as you might imagine, because a biologic is developed from human or animal material, and as we just talked about, it can be more complex to develop it and manufacture it, you can't make an identical compound to it like with a generic. And so it's called a biosimilar. So a biosimilar is essentially the generic type process for a biologic. So a company will develop a biosimilar, and it's called a biosimilar because it's not identical, because it can't be chemically identical, but it's similar through its structure, through what's part of its manufacturing, through its efficacy. And again, it goes through a process at FDA where they evaluate the science, they evaluate the similarity of the product, and they approve the biosimilar. So also safe to take, approved by the FDA, goes through that regulatory process. So as of today, we do not yet have biosimilars in the United States for the MS disease modifying treatments. We do have some generics, right? There's generics for Copaxone and there's generics for Tecfidera. We do not yet have biosimilars for the MS disease modifying treatments.
It's amazing. That's amazing. Thank you very much for that. So a biologic, though, with MS medications, do you know which ones are biologic by nature?
So again, like the rule of thumb to keep in mind will be if it's self-injectable or if it's infused. So, and that's just because of the manufacturing process and the compounds and how it gets delivered into your body. So it's not 100%, but that's a good rule of thumb to keep in mind.
Okay, I was only thinking about it because I know that Rebif has, I think it's Chinese hamster eggs as part of its chemical compound. So I thought that maybe that would be a biologic because you said that it's human or animal material in the product.
Yep, so self-injectable. So yep, it fits kind of that general rule of thumb.
Okay, gotcha. All right, well, that was a good lesson for today. I hope everybody appreciated that because Bari did an awesome job explaining that. And
it's really complicated, yeah.
It's very complicated, yes. And I'm just looking to see if anybody's got any questions on that real quick before I go on to the next thing. And then, oh, there's a lot of questions here. I didn't even see all these questions. My gosh, my computer is awful today. All right, so let's back up a little bit because some people ask questions that related to what we were speaking about earlier, right? And the first one is from Aranda, who says, I had a problem getting my walking drug with insurance. My medical went from $40 to $1,000 per month. A company called Save-On began paying for it. This happened fall 2021 when I turned 63. Why does this happen? What should I do? Is that something that you can answer?
Such good question. And I wish I had a magic answer for you. I can tell you that a scenario similar to what you described, Rhonda, is what takes up a lot of my time and where we're focusing a lot of our energy and our advocacy work. So there's not really a great answer for why that happens, and certainly not one that's satisfactory. Prices increase all the time because they can. I actually just today received updates from a health economics researcher about the price increases for the MS disease modifying treatments so far into 2022, and a number of them have taken price increases 4 to 5%, even some of those medications that have been around since the 1990s. So, the drug you refer to isn't in the DMT category, but it is an expensive medication. It does have generics as well, but there's a lot that goes on within the system of if you think about it, between you meet with your healthcare provider, your doctor, you and your doctor talk about what's going on with you, what treatments you may need. You sort of go back and forth on talking through different medication options, both for DMTs and symptoms and walking. And then your health insurance comes into play. So the doctor may say, I really want to prescribe drug A, and then they learn that it's not covered on your health insurance, or that your health insurance wants you to start on drug B instead of drug A.
Right.
And that's referred to as a preferred drug or step therapy, where you have to demonstrate that a drug doesn't work for you before you can move on to another drug. So, and then there's how much that you have to pay to get the medication that you need. So that's called your cost share. So sometimes it's a flat amount, like maybe it's $20 or $50. That's called a copay. Sometimes it's a percentage of the cost of the drug, and that's called a coinsurance. Those coinsurances are really hard because it's not clear what the coinsurance is based off of. It's hard for you to know exactly how much you're going to have to pay each month, and it varies like that. So the other piece about your health insurance is that your drug benefit, how you get your prescription drugs, can be set up in what's called tiers. So if you think about, we talked about generic medications. So those are typically the least expensive medications that you'll take. And those are often on the lowest tier. Then there's those typical or chemical brand medications. Those will be on a middle tier. And then the expensive or biologic medications will be above that. And each time you go up in a tier, your cost share, the amount you have to pay, is likely increasing. So now the way that it's decided what medication goes on which tier is essentially through contracting and negotiations between your health insurer, sometimes your employer if they're involved in deciding the plan, and the pharmaceutical manufacturer that sets the price. So it's possible, sometimes what we see is that you may have been on a medication that was on a lower tier, and then when you get to the new year, those negotiations went differently, and now that medication is on a higher tier and you have a higher cost share amount. So without knowing a lot of specifics, that's likely what happened in Rhonda's case, is that
Yes.
as she moved into a new plan year, the formulary and the tiering looked different, and now she has a higher out-of-pocket cost for the same medication.
Correct. And I definitely feel that pinch as well with several of the medications, and especially after going on to Medicare, because wow, what a fiasco that has become since. I now feel for all those that are on Medicare and before me and what they were complaining about, because I had no clue until I unfortunately had to get on this as well. And that leads me to another question from a Carolyn who's saying, does Medicare cover cost of specialty drugs once the copay assistance programs from pharma companies no longer are provided?
Yeah, these are great questions. So let's talk about this for a minute. So about 70% of people with MS utilize financial assistance programs to pay for their medications, right? They're very expensive. So the pharmaceutical financial assistance programs are generally only allowed to help people who are in private insurance. So either you have an employer plan or you've purchased a plan individually, maybe you have a plan through the Affordable Care Act exchange. When you're on public health insurance, government-sponsored health insurance like Medicare or Medicaid, those pharmaceutical financial assistance programs cannot provide that support. It has to do with a statute called an anti-kickback statute, where the thought is that if you were able to accept financial assistance from the pharmaceutical company, that sort of induces you to stay on that drug. So that's what that is about. Now, a lot of pharmaceutical companies will provide financial support to a nonprofit, to an independent nonprofit, and those nonprofits then provide financial assistance to people who are on Medicare. So there's about 5 to 8 of them that typically provide assistance to people with MS. They're generally, a lot of times that amount is capped at about $5,000, and it can also be difficult to get. Those programs run out of money with a high level of frequency. But that's one avenue. So, the Medicare drug benefit worked when it was developed. There were some things that didn't work even then, but if you think about when the Medicare prescription drug benefit came to be, drug prices were substantially less then than they are today. And so it just hasn't kept up, and more people have challenges. We know from studies that people with MS will have out-of-pocket costs of $6,000 or more who are on Medicare just for their MS disease modifying treatment. And we all know that people are likely taking many other medications as well, either for symptom management of MS or for other health conditions that we all have, especially as we age. So $6,000 out of pocket every year, it's not sustainable, right? It's not sustainable for people. And this has been a lot of focus in Congress over the last 2 years, and a big focus of the advocacy work of the National MS Society. So one of the things that we're advocating for right now is to redesign the Medicare prescription drug benefit. And part of what would happen in that redesign is that there would be a cap on the out-of-pocket costs. So if you're in private insurance, you know that there's a top level amount that you can pay out of pocket every year that doesn't exist in Medicare right now. So there would be a cap, and depending on different legislative proposals, there's been numbers anywhere between sort of $2,000 to $3,500, $3,700. And there would be what they call a smoothing mechanism, which is fancy terminology for the costs would be evenly spread throughout the year. So right now, if you think about, there's sort of a deductible and there's a coverage gap in the Medicare prescription drug benefit, where people wind up paying hundreds or even thousands of dollars just in January and February alone. So this smoothing mechanism would spread the costs out throughout the year. So we're looking at an out-of-pocket cap, and then spreading even those lower costs that you're responsible for, spreading them throughout the year. So you don't get to January and you're trying to figure out how to pay $800, $1,000 in 1 month.
Yes. And I don't know why, but I'm on an Advantage plan. I'm not going to say which one because I don't want anybody to get me axed for this as well. But I'm on an Advantage plan, and yet they are covering my Tysabri fully, 100%. And I guess I'm lucky to have found this. But I did a lot of shopping first, and did ask if that was covered, as that was the prime reason why I went with this company, is because they were able to cover this. But again, I shopped around for a long time with many of the companies to see if they would cover the Tysabri.
Yeah, and that's smart. That's what you have to do. You have to ask the companies, you have to find out the details about the coverage every year during the open enrollment period for Medicare, which is in the fall. And
Right.
Our MS navigators at the National MS Society can help you do that if you need that assistance. But definitely important to ask those questions, like Stuart said.
Absolutely. All right. Thank you for that. All right. So let me go on to another person's question here. Back to the same person that asked the last one, since this is probably a follow-up. What is the likelihood of this legislation getting passed?
Yeah. So, I never make promises when it comes to Congress, but there is a lot of good bipartisan support. There's a lot of understanding that the Medicare prescription drug benefit is not working for people as we had hoped it would and as it used to. So there's a lot of bipartisan means members of Congress who are Democrats and Republicans, the two political parties, agree that change needs to happen. Now, that's a first step. Getting it across the finish line is always a little more difficult, but that will be a key focus area of ours for our advocacy. And those changes to the Medicare prescription drug benefit that we talked about will likely be paired with some provisions that allow for negotiation in Medicare, that would allow for sort of Medicare as an entity that's a large purchaser of products to negotiate with some drug manufacturers around the cost of those drugs to bring those drug prices down that Medicare is paying for. And then that savings would get used to make those Medicare Part D redesign changes that we talked about.
Right. Thank you for that. So another question came from a person that's asking or saying first that some of the medications that he or she is using are not covered by Medicare, but GoodRx is picking up on it. So how are they able to do this?
Yeah, it's a great question. And GoodRx, there's some other companies that have kind of stepped in to fill some of these gaps that we see, and they're able to do it often at substantially lower cost.
Right.
So, you know, everyone has to weigh that individually. So it is great that you can get some of your medications at a substantially lower price. You have to know too that that means it's not counting towards your health insurance. So if you have a deductible, if you have a cap on out-of-pocket costs, if you're going outside of your health insurance through a program like GoodRx, then what you're spending in GoodRx isn't counting in your towards your deductible or counting towards your out-of-pocket costs. It doesn't mean it's bad to do. It just means I want to make sure that you're aware and weighing both the pros and cons. So, why can GoodRx cover it and not Medicare plan? Well, right now, Medicare, those prescription drug plans are separate entities that are operating under the Medicare umbrella to provide a prescription drug benefit. So much like private insurance, like we talked about a little bit, they're going through the same process and looking at what are they going to cover, what tier is it going to be on, what's the out-of-pocket cap cost going to be. There's some rules within Medicare around things have to be actuarially equivalent. So ultimately, the plans can't be super different at the end of the day in terms of costs to people. And there are some rules around the number of medications per category, so type of medication that have to be covered. But it's really easy to see in a class like MS where there's more than 20 DMTs. It's easy to see that it's going to be really hard to find a plan that covers all of them. And that's why, again, that sort of shopping around and asking those questions is really important.
Great. Thank you for that. Next, and a person named Elizabeth. What are the biggest specific cost drivers for patients with MS, drug therapies, testing, caregiver costs, etc.? Where can patients with MS find help?
Yeah, thanks for that question, Elizabeth. The biggest cost driver for people with MS is the disease modifying treatment. So, and if you're on one and it works for you, keep taking it because it's super important and it's the best way we know to slow the disease course and stave off that disability. But the bottom line is that insurers will say that it's about the disease modifying treatment is about 75% of the cost of treating a person with MS. So we will have more information coming out soon around the costs. So the National MS Society partnered with the Lewin Group to do an economic burden study. And we're actually awaiting publication of the paper right now. It should be within the next couple of months. And there were two parts to it. So it looked at health claims data. So it essentially went and looked at what insurance paid for people. That's called health claims data. And then there was also a survey of nearly 1,000 people with MS, asking a lot of questions around the costs. And it looked at both direct medical costs, so things that Elizabeth mentioned, like your DMT, lab work, hospital stays, all of those things. It also looked at indirect costs, things like productivity in the workplace or retiring early, right? So, and it looked at both of those and looked at caregiving as well. So all of that is going to be in the paper and the report that we'll be able to share more widely and really raise the level of this conversation in the next couple of months.
Okay, great. Thank you for that. All right, let's go back to a question that we had for you. Okay, and that is, are there any current policies that the MS community should know about that could impact them?
Yeah, so there's two things that I want to highlight for you. So one is that, there were a lot of COVID relief packages that came out of Congress over the last couple of years. So there were a lot of pieces in that. So things like paid leave and tax credits, some food security pieces, lots of things that really support economic security, making sure that people can manage through the pandemic that were in there. Also, there's been a lot of expansion of telehealth. That it was sort of, some refer to it as the silver lining from the pandemic. You know, pre-pandemic, lots of people were talking about telehealth, and it was really hard to get traction to expand it. But it exploded during the pandemic because we didn't have other options. And we're working hard to make sure that telehealth continues to be available to people who want to use it and improve access to their healthcare that way. And then the other thing that I want to mention is a law that's called the No Surprises Act went into effect on January 1st, 2022. So this law passed back, I think, in the end of the calendar year 2020. And then 2021 was spent developing regulations and making sure how to implement the law. So the No Surprises Act is around what's referred to as surprise medical billing. And so what is that? So it's when you go see a healthcare provider that you thought was in your health insurance network. So you thought they were covered by your health insurance, only to later get a bill that surprises you because that bill is a lot more than you thought it was going to be, because all of a sudden you're learning that that provider was not covered by your insurance. So the No Surprises Act seeks to address that, to sort of have that conflict around the bill be worked out between the healthcare provider and the insurance, and to leave the patient out of it. So there's a few places where this typically comes up and that are covered by the No Surprises Act. So one of the most common is in the emergency room. So if you go to an emergency department, and very often you don't have a say over what emergency department you wind up in, right? You go to what's closest, you go where the ambulance takes you. So the emergency department is one of the most common places where this happens. And so now that will be in network for you. So you will pay the in-network rate, which is that reduced rate. And the other places where it typically occurs that is now protected by the No Surprises Act is if you are seeing a provider who's out of network, but at an in-network facility. So that's a lot of complicated words, right? So what does that mean? It means that you go to your local hospital that you know is covered by your insurance, right? So that's in network, it's covered by your insurance. But unbeknownst to you, there are doctors and lab technicians and things like that that work in the hospital that are actually contracted employees. So they're not actually covered in network for you. A lot of times this happens with anesthesia. It can happen with pathology or lab work. So, and again, you know, many times you don't have control over those things. They tell you to get lab work, you're getting lab work. You're not stopping to ask if the person reading your lab work is covered by your insurance, right? That's certainly true of anesthesia as well. You know, if you're going in for surgery, you may not have control over when that is and who's providing the anesthesia. So the emergency department, providers that are located at an in-network facility for you, those are now covered by the No Surprises Act. So if there's any of that conflict between, you know, the provider says, well, really it costs this much, and the insurance is saying, well, I'm only paying this much. In the past, they would send you the bill for the difference. You won't get that bill for the difference anymore. They'll have to work that out themselves, and you'll only be responsible for what you are under your health insurance.
That is great to hear. Great to hear.
Yeah.
I had an MRI one time during COVID. I couldn't go to my standard one, and so I had to go to another one that was listed in my policy. But the person who read the MRI was not in the policy, and I had a good battle with them about this. But again, I take care of it. So, and that's what most people don't do, though, is they don't know how to wage the war on the injustices that are happening to them. All right, so that was a great information that you just provided. What are the current priorities on policies today?
Yeah, so we've talked some about drug pricing and the Medicare prescription drug benefit. So those are top priorities. I mentioned telehealth as well, right? We're continuing to work on telehealth access. And we're also focused on MS research funding. So that's always a priority for us. So that happens in a few different avenues through the federal government. So one of those is through the National Institutes of Health, NIH. You may have heard it referred to.
Sure.
And NIH is the premier biologic research institution for the United States. So when we advocate for funding for NIH, we're advocating for overall funding for NIH. And then different projects in MS may get funded, and there may be projects that are funded that sort of cross into MS as well, like projects that look overall at the brain, right? There may be learnings from there that are relevant to MS. There's another area of funding that's specifically for MS research, and that's called the MS Research Program, and it actually sits in the Department of Defense. But through that, there's a specific line item, so designated funding for MS research, that to date has funded about $93 million worth of MS research. And so this is funding that needs to be specifically appropriated by Congress every year. So every year, Congress needs to say, yes, we're going to fund that program at this amount. So we've been at $20 million a year for the last couple of years. We're going to bump that up a little bit to account for inflation and ask for $22 million. And it's a great program. They tend to fund more what's referred to as high risk, high reward research. So, NIH will look at what are proven concepts in research that we want to move forward to the next phase. Through the MSRP, they may be more willing to take an innovative idea that doesn't necessarily have that proof of concept behind it yet, but if it pays off, it will pay off big. And so that's a lot of the work that the MSRP does. So exciting opportunities for research funding, and something that we'll be advocating for again this year.
Thank you. So recently, the Department of Defense MSRP person contacted me and asked me if I could help to nominate MS patients that they could use for their review panel. They explained it all as, having the consumer, the MS consumer, to listen to the research that's being provided, or the research grants that are coming in, so that way the MSRP actually decides what's going to go forward to their panel for who actually grants the grants, okay, based on what the consumer, the MS patients, say about the different research projects. I found it very interesting, but I do want to learn more about it. I do want to nominate people. I have people in mind already for this, but if anybody listening today wants to be part of that, you better be good to me, okay? All right.
Yep. It's a great aspect of the program. You're right there, sort of in the room, or these days in the virtual room with scientists and researchers. You're able to give your perspective on what you think the research might mean for people with MS. The society has nominated quite a number of people with MS who sat on that panel. They've all loved it, and I'm happy to put anyone in touch with people who've done it to find out a little bit more.
Yeah, they were telling me that they use the same people like for a couple of years, but then they rotate out. So, so now they're looking for, other patients to be part of this as well. And they did tell me also that they are going to try doing some of their panels soon to be live, but she couldn't, basically, she said some are going to be virtual, some might be live, but they haven't worked out their parameters on that yet. Okay. Next, every year the National Multiple Sclerosis Society's Public Policy Conference takes place. Can you please explain to our audience what this is about, tell us exactly what this is and how they can be directly involved.
Yeah, I'm happy to. This is one of my favorite all-time things every year. So, the Public Policy Conference, we have a few goals for it. So, one, it's a time to make connections across the MS community. It's a time for us to celebrate MS activists, those people who engage in advocacy work. And it's a time to be able to educate people affected by MS on policy issues like some of the ones that we've talked about, and also provide tips and information to people on how to best communicate with elected officials and their staff to get your point across, and provide some tools for people to do that. So the Public Policy Conference is an annual event for the MS Society. It has been around for just over 30 years. And so we usually time it to happen in March. And the reason for that is that that's when the appropriations or funding cycle for the next year kicks off in Congress. So we want to be able to hit at that time to really advocate for that MSRP funding that I talked about. So this year's Public Policy Conference will be virtual. So that does mean that we're able to open it up to everyone who wants to join for free. It is a requirement that you register, but there is no cost for doing so. And you can join all or part of it. And so this year it will be Monday, March 7th. So that's coming up. Monday, March 7th. It will run from about noon to 5 p.m. Eastern time. So we'll have a couple of issue panels where we bring in some guest speakers. We talk in depth about those issues. This year it will be that MSRP funding, and it will be affordable access to health insurance and prescription drugs. So really hitting at some of the prescription drug issues we talked about, the Medicare Part D redesign, and some other health insurance pieces as well. So those will be the primary issues that we'll focus on at the Public Policy Conference. We'll also have video chats and breakout rooms where people can get to meet other MS activists, people with MS, have some more detailed conversations. And I'm excited to share that CNN's John King will be joining us as a guest speaker. So you may know that he recently shared that he has been living with MS for about 13 years. So we're excited to have him come on and talk a little bit about his experience and the importance of sharing your story with elected officials.
Right. How do people get signed up for this?
Yeah, it is super easy, and you can actually do it right now if you want to. So if you have a phone handy, you can take that out and you want to text the letters PPC, that stands for Public Policy Conference. So text the letters PPC to the number 52886. So 52886. Yep, is the number, and text the letters PPC. And then the automated response will send you the registration link that you need to fill out.
So PPC is in Public Policy Conference.
Yep, to 52886.
Okay, gotcha.
So as of earlier today, we're at about 700 people registered so far, and I hope that you'll all join us.
Great, thank you. It's funny, as I asked that question to you of how people can get registered, like 6 people were typing the question to me to ask how to get registered. So I guess you're going to have at least 6 people. So I guess you're going to have at least 6 more people on there. All right. Okay, great.
That's great.
That's absolutely fantastic. What changes have you seen implemented as a result of the work and efforts at the Public Policy Conference?
Yeah, so let me talk about a non-policy one first, right? So one of the changes that I see, and this is why I love the Public Policy Conference so much, is that I can see the difference in people who join the Public Policy Conference. So you gain that confidence and understanding, and like Stuart talked about, sort of that willingness to fight back, to push against your health insurance, to push against some injustices, and to really ask for what it is that people with MS need to live their best lives. And so we're virtual this year, we were virtual last year. When we're able to be in person too, I can actually see that moment in someone's eyes when they start to feel more powerful and more confident and are ready to advocate for themselves and others with MS. So my favorite moments of all time. So on the policy side, right, that MSRP funding, that $93 million to date, that all started from previous public policy conferences where we first got that program as part of the Department of Defense research funding, and then we go back every year to get it funded. That would not happen without that big push that we're able to do as part of the public policy conference. The No Surprises Act that we just talked about also was a big policy priority issue of ours at a previous public policy conference. So, and it shows you the different kinds of things. So, the MSRP funding is MS specific. We're really the ones leading that. We have to bring our voices and really push for it. The surprise medical bills impacts lots of different people. Lots of organizations were out there advocating for it. But we also had an important voice to bring to the table, and we were able to do that through the public policy conference. So those are just two recent examples.
Okay, thank you. People are telling me that they're trying to text the PPC 52886 and nothing's going through. How does that happen?
I don't know. I'm going to try it right now on my phone.
Are they supposed to send a note with it?
No, so where it says 2 at the top, that's where you put in the number 52886.
Oh, okay.
And then when you get to the text message content part, where you would typically write a message to someone, that's where you type the letters PPC, and then you hit your send.
Gotcha.
Yep. And then in just a moment back, yep, you get the link.
Great, that makes a lot of sense. I hope people understand that. I think when you were first saying it to, just send it to PPC 52886, they were trying to send it to PPC 52886.
Yeah, we had that trouble the other day. Yep.
Okay.
So the number that you're texting to is 52886, and then your message is PPC. Maybe that's a better way of saying it.
Great. Yep. All right. So for the few people that wrote in that it wasn't working, I hope you tried it now. I hope it worked for you. And yeah, we had some people scream out that it's not working. We had other people yelling out, yes, it works. So thank you for that.
Great.
So,
well, I love the real-time feedback, so we can make sure to get you all registered. So thank you.
Absolutely. Absolutely. And speaking about real-time feedback, when we were talking about earlier, and I'm going to get back to that for a brief second, when we were talking about, let me look at my notes, it's about the pandemic and endemic dialogue that you guys are having tomorrow. Where can people watch that?
Yep, so you can go to our website, nationalmssociety.org. You can go directly to that section if you do nationalmssociety.org // See, I always get them wrong. Help me with the slashes, Stuart. Hang on, I wrote it down so I could share. Yep, there you go. /MS expert, right? So you can do that. Or you can just go to nationalmssociety.org and in the search bar, do Ask an MS Expert, and the whole series will pop up.
Okay, great.
Also, you can go to Facebook tomorrow at 1 p.m. and go to the National MS Society page, and it will be streamed live there. So a few different ways for you to find it.
Great. Do they have to fully type out nationalmssociety.org, or can they do to nmss.org /MS experts?
I don't know. That's a good question. I'm sort of trained not to do the abbreviation, but you can try it and let me know.
I'll do that separately. I can't do it right now because I'll lose our link. All right.
Yeah.
Okay. So going forward, so you spoke about the policy, the public policy conference and the work efforts that you do. Can you share a link where, that's the question of where, share a link of how people can get involved. Wow, it's actually part of what I was actually talking about already. So let's back up on something else. And that is that we were talking about, I wanted to make sure certain things were hit. Can you explain what the MS Society actually does to help reduce the drug pricing? I mean, I know you spoke about this a little while ago, but I'm more specifically maybe of how you battle. I mean, who is it that you're seeing, and how much longer do people have to wait to maybe see some of these prices come down?
Yeah. Super important questions. So here's the thing, is that these drug pricing issues are really complicated. And that doesn't mean that we're not going to get there, because I do believe that we are. But there's lots of different entities that have a stake in this, and they all make money from it. And so each one needs to be addressed. And that's part of the work that we do. So as we're addressing drug pricing, we're addressing it through public policy, so federal and state legislation, also through individual, sort of a smaller letter A. If you think about capital letter A advocacy at the government level, smaller A advocacy with individual companies across the healthcare system. So, the pharmaceutical manufacturers that develop the products, we talked about them a little bit, they're the ones who set the price of the product and who do price increases every year. So we talk to them a lot about what is an appropriate price at launch when a drug first comes on the market, right? Looking at how it compares to other medications, the value that it brings, how is it different, what stands out, those price increases, right? I think there's a valid conversation to be had as to whether a medication that's been on the market for over 20 years should still be regularly increasing in price. And those are some of the conversations that we push forward and have, both with elected officials and also with companies. There's also, we had some questions around the out-of-pocket costs that people have. So there's conversations to be had with health insurers about those co-insurance that I talked about, co-insurance instead of a copay, right? That's really problematic for people who rely on expensive medications. The tiering that we talked about as well can be really problematic. And step therapy. So when essentially your health insurance is telling you what medication to start on rather than you and your healthcare provider or doctor determining that. So step therapy is one of those other pieces that we advocate for, both at the federal and state level, so at that government level, to have better consumer protections across it, but also really talk with health insurers about that as well. So there's other entities, even more in this drug ecosystem, that make it even more complicated. Sometimes a health insurer is not making the decisions around its drug formulary itself. It contracts with an agency called a pharmacy benefit manager, or a PBM, to do that work. So then we need to talk to the PBMs. I know many of you probably have the experience of you're told what pharmacy you have to get your medications from, right? So and it's a specialty pharmacy, so lots of times it's not local. You can only get it through the mail. Maybe that works for you, maybe it doesn't. I've heard from people who've had experiences of, medication that required refrigeration, being left out in the sun all day, things like that. So that's another avenue of advocacy that we pursue too. So there's no shortage of work in this area. And the more we hear from people with MS, we're able to highlight the direct experiences and perspectives and stories of people with MS to really drive home these points around how these policies aren't working.
Well, thank you for that. And thank you for everything that you've taught us tonight, because this has been quite inspirational and educational. And I don't have any more questions for you. If anybody else does, that would be great. But we're going to wind down right now, and just say again, I want to thank you for being here. I will be putting out. I want to let you know that I'm going to put out on our different social medias for people to register for the conference. All right, and if you want, I'll tag you on every one of them, but I don't think you want that.
That's great.
All right.
Do it.
Okay, great.
Yeah.
All right, that's great. And yeah, I think it's very, very important. I think the more people we could get involved and speaking their minds, that it would be better for everybody else. So, and not just for themselves. So, you know, I'm going to ask everybody that's here tonight to tell your friends about this link. You know, go online, go to your social media pages, and get people involved, because you know, you want things to happen, you're going to have to get involved to make them happen. You can't just sit back and let everybody else do for you. You've got to become your own advocate. As you've heard, you know, from me, you've heard from others that we have fought for things that we needed. So, you know, you too are going to have to do that and share with others how you can even, you know, make that happen for yourself. Okay, but Bari, Talente, thank you with an E. Thank you very, very much for being here. Thank you very, very much for being online. We hope to have you again in a few months, maybe after the conference is over. Maybe we can, who knows, maybe we'll just bring you back on so you give us an update on everything that's happened. Okay?
That's great. Thank you so much, Stuart, and thanks to everyone who joined.
Great. Have a great night, and good night, everybody. Bye-bye.
Bye.